A 55-year-old man sits in the exam room. He's been noticing some clumsiness lately, dropping his car keys, struggling with buttons, and his family mentions his speech has started to slur. During the physical exam, the doctor looks at his arms and notices visible muscle wasting. Under the skin, the muscles are rippling and twitching on their own, a phenomenon called fasciculations. These are classic signs that the lower motor neurons, the nerves directly connecting to the muscles, are dying. Neurology operates on a reliable set of rules. If the lower motor neurons are damaged, the reflex arc is broken. So when the doctor taps his knees with a reflex hammer, you would expect a dead, diminished response. But the doctor taps the knee and the leg kicks out violently. The reflexes are incredibly exaggerated. And when the bottom of his foot is stroked, the toes fan upward. These are textbook signs of upper motor neuron damage, meaning the failure is happening high up in the brain and spinal cord. This is a direct clinical contradiction. You have upper motor neuron damage and lower motor neuron damage existing at the exact same time. Yet, when the doctor tests his ability to feel pain or a light touch, his sensory system is completely flawless. This combination of upper and lower motor failure, alongside a perfectly preserved sense of touch, points to one specific diagnosis. It is amyotrophic lateral sclerosis, or ALS, the most common and devastating form of motor neuron disease. Looking at this medical summary, we can define the golden rule of motor neuron disease. It is a purely motor condition. The primary defect starts right here in the anterior horn cells of the spinal cord. Think of your body's movement like a two-part electrical cable. The signal starts in the brain, traveling down the upper motor neurons, then hands off the signal in the spinal cord to the lower motor neurons, which carry the current out to the muscles to make them contract. In MND, that specific motor cable starts fraying and shutting down. But while the motor pathways disintegrate, other systems are entirely spared. A patient will maintain completely normal physical sensation, full control of their eye movements, and preserved sphincter and bladder control. The tragedy of this disease is locked within that specific biology. Understanding motor neuron disease requires knowing that its destruction is strictly confined to the motor wiring. Knowing what the disease ignores is just as critical for diagnosis as knowing what it destroys. Because of how that wiring works, motor neuron disease isn't actually a single illness. As we see in these clinical notes, it's an umbrella term for 4 distinct subtypes. The type you get is dictated entirely by which part of the motor circuit fails first. Amyotrophic lateral sclerosis, or ALS, accounts for half of all cases and features that mix of upper and lower motor neuron signs we saw earlier. Right below that is primary lateral sclerosis, which exclusively attacks the upper motor neurons. If only the lower motor neurons fail, it's progressive muscular atrophy. This usually hits the distal muscles, like your hands and feet, first, and comparatively, it carries the best relative prognosis of the group. On the other end of the spectrum is progressive bulbar palsy. This variant attacks the motor nuclei right in the brainstem, rapidly destroying a patient's ability to swallow, speak, and control their face. Because it threatens the airway so quickly, it carries the worst prognosis. And even within brainstem symptoms, we have to distinguish the exact circuit damage. This table shows how true bulbar palsy, a lower motor issue, causes a wasted, twitching tongue. Meanwhile, pseudobulbar palsy, an upper motor issue, causes a stiff, spastic tongue, and often comes with uncontrollable crying or laughing, known as labile emotions. Ultimately, MND presents as a spectrum of localized circuit failures. The specific anatomical location of the short circuit dictates the terrifying specificities of how a patient's physical abilities will decline. Handing down an MND diagnosis is one of the heaviest moments in medicine. Because there is currently no cure, doctors have a strict ethical obligation to systematically hunt down and rule out any treatable conditions that might just be mimicking the disease. As the text here highlights, a crucial step is ordering an MRI. A slipped disc compressing the cervical spinal cord can actually pinch lower motor neurons at the neck while squeezing upper motor neuron tracts heading to the legs. It creates an artificial mix of upper and lower damage that mimics ALS perfectly. Once compression is ruled out, the definitive test is electromyography, or an EMG. By inserting a fine needle directly into the muscle, doctors look for fibrillations. These are erratic, spontaneous electrical spikes that prove the muscle has truly lost its nerve supply. Even with those tests, certain clinical red flags immediately halt the diagnosis. If a patient has sensory loss, say numbness from diabetic neuropathy, or if they have bladder dysfunction, the diagnosis simply cannot be MND. Diagnosing motor neurone disease is a rigorous exercise in elimination. You must prove beyond a shadow of a doubt what the condition isn't before accepting the reality of what it is. While visible wasting of the limbs is what people notice first, the true threat lies elsewhere. As we can see under respiratory involvement, bilateral diaphragmatic weakness is present in up to half of cases at presentation, and respiratory failure is the most common cause of death. The median survival time from symptom onset is just 3 to 5 years. For pharmacological management, the primary medical drug offered to patients is riluzole. Riluzole acts as a glutamate antagonist. It blocks the release of glutamate into the brain synapses, limiting the toxic buildup of this neurotransmitter that accelerates nerve death. It prolongs life by roughly 3 months, though it requires strict monitoring to prevent severe liver toxicity. But looking at the respiratory care notes reveals a surprising fact. The single most effective intervention isn't a pill at all. Non-invasive ventilation, typically a BiPAP machine used at night, actually provides the greatest statistical survival benefit, extending life by around 7 months. This highlights the overarching tragedy of motor neurone disease. The mind remains entirely aware, perfectly intact, and capable of feeling everything, while the disease systematically locks away the entire motor capability of the human body.